Quite often in our clinic, when I do a full body check, I find small belly button or umbilical hernias. And of course, I bring patients' attention to that. And when I say that, they usually say, oh no, I don't have a hernia, or nobody told me, or I don't have a pain, or I don't have a bulge. How can you tell that I have a hernia? Well, a simple test to know if you have a hernia is a very simple and crude test. If you take your index finger and gently, the operative word is gently, push on your belly button. If you feel emptiness or you feel something that feels like a ring, that actually means that you do have a small hernia. So why is it even important? So interestingly, there are two ways of looking at hernias. So we have a lay person's way of looking at hernia, which is a bulge, but you also have a surgical way of looking at the hernia, which is actually a hole or a hernia defect. So, but the reason I bring up this with the patient, and we actually always talk about it, because having these even small and asymptomatic hernias could have life-threatening repercussions in some cases, not frequently, but in some cases. So today's video is all about umbilical hernia, what are the symptoms and what types of hernia they are, and when they should be fixed, and when there's some situations where they could be left alone. Welcome back. I'm Dr. Maria Azizian, a board-certified general surgeon and IFM-certified functional medicine physician. So when a baby is born, the baby is attached via umbilical cord to the mother, and umbilical cord is cut, and then the umbilicus or belly button is formed. And at first it's quite weak because the muscles and fascia of the abdominal wall has to sort of develop in that area to get rid of that weakness of that opening, because that's where umbilical cord was. So when there is a hernia in a baby, that's actually not that unusual. And in many cases, hernias in babies up to 5 years of age are not repaired, are not fixed, because they often close and repair sort of themselves by themselves. So they close by themselves. So there's often no need for any surgical attention. Of course, there are exceptions to that. However, some of these some of that weakness at the umbilical area doesn't go away, and it persists in adulthood, and that makes this person already starting out with a small hernia, and then it continues. So that hernia is due to embryological development, so to speak. What are the factors that contribute to hernia development in general for any adult? So there are very common factors, but they all have the same denominator, which is increase in abdominal pressure. So if there is an increase in intra-abdominal pressure, then there is more pressure on our abdominal wall, and of course that predisposes one to a belly button or umbilical hernia. So those factors are persistent coughing. For example, if somebody coughs a lot due to COPD or whatever is the reason, or let's say they're a smoker with COPD, that's a common scenario. There's a constant strain on the abdomen. Another strain type of situation is heavy lifting. If your work involves heavy lifting, yes, there is a higher probability that you will develop hernia. It doesn't mean that everybody who does heavy lifting develops umbilical hernia, but it is more likely. And another one that's very important and people forget about it is constipation, because when you strain with having a bowel movement, then you are predisposed to having umbilical hernia. Not only umbilical hernia, you can have other hernias too. So, but today we're talking about the umbilical hernia. So yes, constipation with straining, especially chronic constipation, not occasional constipation, but chronic constipation would predispose you to the umbilical hernia. The other factors are obesity, of course, that's just more pressure on the abdominal wall, which consists of fat, muscle, and fascia, which is a strong connective tissue layer. And another one is pregnancy. It is very common to see small hernias even in very slender women from their pregnancies, and you can have only one pregnancy but develop a hernia. So again, it's sort of hard to predict who will develop a hernia. Some people may carry and have 3-4 pregnancies without developing umbilical hernia. So how do we look at the hernias in the medical surgical world? But before we move on, if you are enjoying this video, please don't forget to like, share, and subscribe so you can have access to more of my videos about everything surgery, functional medicine, vitamins, minerals, and skin health, and so on and so on. So let's talk about sort of 3 types of hernias that we see. So the first type, or the more common type of hernia, is what people think when they think of a hernia, which is an abdominal wall with a bulging. So with this type of hernia, the first question is, so what does that bulge contain? What does that bulge composed of? So that bulge essentially is fat. Usually it's fat. Sometimes there's some intestines could be part of that bulging. So we have a hole, or rather I will call it a hernia defect. So there's a hole that allows the contents of our abdomen protrude through that hole, and that protrusion is actually the bulge, that what people call a hernia. In most cases, that bulge contains either fat that is part of the abdominal wall, and in some cases it could be fat that is part of the omentum. Omentum is a fatty layer. It's like an apron-like layer that is attached to our intestines and stomach, and that omentum could get caught in that hole. So, and with these types of hernias, when we see patients like that, the key is to make sure that this bulge could be reduced, meaning when you gently press on it, and we usually do it when the patient is lying down, so their abdominal wall, abdominal muscles are relaxed, and just gently push the contents of that bulge in, and in most cases it goes in. So that is called a reducible hernia, because we can reduce the contents back into the abdomen, and that's very nice because that is a less concerning form of a hernia. People who have this sort of classic presentation of hernia usually have symptoms. Not always, they could be asymptomatic, but usually they have symptoms such as pain, and pain could be intermittent, meaning that it comes and goes sometimes. Pain could be persistent but dull and mild, like it's always there. Also, a lot of times these patients talk about this sensation of something going in and out, because indeed that intestines with the fat, or just fat, whatever it is, that does go in and out. And another symptom is when they only have pain, let's say when they lift something, or sometimes they may strain with having a bowel movement, or let's say they're laughing very hard, like a belly laugh, and they do have that unpleasant sensation or even pain associated with that. So in many cases these people are symptomatic. Because they are symptomatic, the surgery is indicated for them at some point. And usually the way we look in the surgical world at the repair is that it's always better to repair a hernia when it's small, meaning when the opening is small. And I have to point out here that the opening actually could be small, but the bulge could be very big, because over time some fat and the intestine, they can come through a very small hole. So by looking at the bulge, it doesn't tell you the size of the hernia. You can have a small defect with a large bulge. Of course, for a surgeon, a small defect is the best because it's easier to repair. If you have a small defect, let's say something 10 millimeters, like this much, it's a small defect. If you have a small defect like that, then it could be repaired with sutures, with stitches, and it's much easier repair than if you have a large defect. Let's say if you have a defect like this type of a defect, you would have to put a mesh, so you would have to put essentially a foreign body screen in that area, just almost like patching anything, like patching a hole in the tire. So you want to patch it with something, because you can't just close it with sutures, because if you only use it suture stitches to close it, it will open up. So so the size of that hernia defect is very important. When these people are scheduled for surgery, two important factors are discussed with the patient. Number one is if there are smokers, it's strongly advised, and I even know some patients who would, some surgeons who would not operate on patients who are smokers until they stop smoking. But even stopping smoking for 2 weeks, even for 2 weeks, that does make a difference. It does make a difference in postoperative healing, in the recurrence rate of the hernia. So smoking really does have an adverse effect on the development of the hernia, because it creates chronic cough, and also on a postoperative course, because it really affects your collagen, it affects your connective tissue, it makes you weaker, it makes the repair less effective, etc., etc. So that's why some surgeons actually would not operate on certain patients who are smokers until they stop smoking. So smoking is one factor. The other very important factor is obesity. And obesity, I think, is harder than smoking, because with obesity, you can't lose weight that fast. You can't lose significant amount of weight in 2 weeks, for example. So in some cases, the patient is made to wait a little longer so that they could lose substantial amount of weight. Why is that? Well, it's sort of intuitive, because the more obese somebody is, the more pressure there will be on a new repair. So the possibility of recurrence, the likelihood of recurrence of hernia, meaning that the mesh or the sutures and things will open up and recur, is much higher. So that's why obesity and smoking, they're two very important factors. Of course, there are other factors that I will not go into in this video, for example, liver cirrhosis and etc. So, but sort of common factors, smoking and obesity, there are two things that would make a surgeon wait before operating. So and that's for people, again, so our first category, people who have a classic hernia bulge. Now we are in a second category. Those are the people that I started my video with, that are people with incidental hernia, meaning that they have a tiny hernia defect. And with these group of people, the key is, again, the size of the hernia defect and their symptoms. And if obviously they didn't even know that they had a hernia, that's a good sign, as I always say, because it means that they could be left alone. So why do I even bring it up? Why do I tell them that they have a hernia? The reason I bring it up, and we're sort of slowly moving to a third type of hernia, is that even with the smallest defect, like 10 millimeters, something like that, a 10 millimeter hole in your belly button, you could have intestine caught in it. And it's very nice if it goes back in, if it reduces, as we discussed earlier. However, sometimes in some rare situation, the intestine can get caught in the hole and it can't go in, and it can even get twisted. So when it gets caught in the hole, it's called incarceration. But when it gets twisted and intestine starts dying, becoming necrotic, that's actually a bowel strangulation. It creates a bowel obstruction. It's a very significant, life-threatening situation. So when I point this out to my patients with this small asymptomatic hernia, I always tell them and list the signs that they should look out for if that were to happen. So, and we're moving to the third type of hernia, which are incarcerated hernias. So incarcerated hernias, I'll just repeat it, that it's when something, it could be fat or a bowel stuck in the hole. However, when it's the bowel or intestine stuck in the hole and it starts becoming compromised, we're having a strangulated hernia. And strangulated hernia may occur in both types of patients, in our first classic group that had a bulge that was visible, and in these patients who have very small hernia that they were not even aware it was there. And the likelihood of this happening is somewhere between 5 to 15%. So the signs of strangulation, incarceration and strangulation, because they go together, first of all, is the fact that you can't pass gas, you can't have a bowel movement. Usually there is significant nausea, vomiting, and very often, especially sort of later in the development of this condition, there are skin changes over the hernia where you have the hot or warm sensation, the skin becomes red, and those are all very, very important signs. So if that were to happen, honestly, it's not a subtle presentation. It's not subtle at all. So most people would call 911, and I just reinforce with my patient, if they ever see this happening, to call 911 and not to wait for this to get better. This is not some abdominal infection. This is something serious that need to be repaired, surgically repaired ASAP, and it is considered a surgical emergency. And indeed, when these patients present to the emergency room, they usually end up in the operating room. Of course, there are efforts made to reduce it gently. There's little tricks on how to do it, but unfortunately, if patient presents too late, then it's too late to do that, because the bowel is already compromised and the patient has to go to the operating room. And in some cases, patient ends up with a removal of a section of the intestine, where that section that became dead or partially dead usually is removed. So that's why it is a surgical emergency. So incarceration and strangulation, those are surgical emergencies. However, if a person with this asymptomatic tiny hernia do not have any symptoms, and they are slender, and they're a non-smoker, they don't strain, and all is well, elective repair is elective, so it's optional. They don't necessarily need to have it repaired. Ideally, it's nice to have it repaired, but again, in a slender person without constant straining with a small hernia, the repair is not absolutely indicated, and they could just live their life until they become symptomatic, or perhaps they will never become symptomatic. So this is basically umbilical hernia in a nutshell. I hope you enjoyed this video. Please share in your comment your thoughts about umbilical hernia and their diagnosis. So I'll be excited to read them. Thank you so much. Until next time. Bye-bye.